We would like to start the 5th webinar session in fetal cardiac imaging using MRI. Welcome everybody to the session today. We are handling the mastering the technical challenges of fetal CMR. And directly at the beginning, I would like to mention that this webinar will be recorded. Yeah, and today it's me. I'm Heide Böth. I'm Clinical Affairs Manager and Customer Relations at North Medical, together with Fabian Cording. He's founder and CEO at North Medical, and we are very happy to do the moderation for this session today. And yeah, we are happy to welcome all of you. So as you all already might know, that we have a series of 6 different sessions in our webinar. And today it's already the 5th session with the title, as I said already, Mastering the Challenges of Fetal CMR Planning. And just to let you know again that we have each session recorded, and the recording is available online on our website. Also the session today, as I said, will be recorded. And just also to let you know, in 2 weeks, June 7, there will be the last webinar session of this series. And this will be held by Julian Lütgens from Bonn, and he will present an online case, which will probably be also very exciting. So you should also register for that one. All right. Yes, it's our biggest aim with this webinar series to build a community and to offer a platform for networking and for an exchange. And here actually it's very important for us to get the transfer from those users that are already using fetal CMR for a longer time to those users that have just started, because as fetal CMR is very, very new and innovative, it's very important, we believe, to do this networking. And during our last webinar session, we have tried a new format, and we would like to keep it also for today, and which is that each participant is allowed to talk and also to discuss with our experts. So if you would like to talk and discuss, please raise your finger to show us that you want to speak, and then we will enable you to speak. So you are welcome to do so. If you don't want to speak, it's also fine. You can just paste your questions directly into the chat, and then we will raise them. It's also fine. I'm very, very happy and proud also to present our experts today. It's on the one hand, Marjolaine Peak she's an engineer from Lund Cardiac MR Group in Skane University Hospital in Lund in Sweden. And Marjolaine will talk today about fetal CMR, how to get it started. So welcome, Marjolaine. And then we have also 3 further users that will be there today for a clinical experience interview, and they will also show some clinical cases. And yeah, we welcome Roland Kronenberg from Vienna, Munis Fares from Dallas, as well as Sophia Stöcklein from Munich. And I'm very happy that you're all here. And now I will directly hand over to Marjolaine. Please share your slides, Marjolaine. And yeah, I wish you a good hour.
Good. Thank you. Thank you for your introduction, Heide. So just a little bit about me. I'm a PhD student in Lund, and my background is in engineering, not medical. So just start with, so why would we do fetal CMR? I will keep this short, as you've heard this probably many times already. So in Lund, we have been doing fetal CMR since 2014. And why would you do it? Well, our colleagues have published a paper in 2021 about the utility of fetal CMR for diagnosing complex congenital heart. Included 31 fetuses with suspected complex CHD based on echo data. And what they found with cardiac CMR, that it provided to be clinically useful in 84% of the cases, and it improved the parental counseling in 68% of the cases. But moreover, because CMR added a lot of data, it improved the confidence of the physician in the diagnosis. So, just to show you one example, and I have more if you're interested in it, please ask me after this talk. So this case is a healthy volunteer in week 35 of pregnancy. On the left, we see the echo, and we can see there's a lot of shadowing happening. But on the right, we have the CMR image from the same day, and we're scrolling through a transversal stack here. And we can see that there's a very good view of the heart and the main vessels. So just one of many cases. So what is the general setup for fetal CMR? So we'll talk to you about the scanner, the team that we have put together, and the safety. So first of all, we use a 1.5 Tesla MR scanner in Lund, but you can use a 3 Tesla as well, or even a low-field scanner. On the right, on the top right, you can see a mother-to-be lying on her left side with a flex skull on her abdomen to get signal from the fetal heart. And in Lund, we are using the left lateral position because on the back, on supine position, we could press the vena cava, thereby obstructing blood flow. There is some ongoing research about this to see if this is actually the case, but we have also found that most mother-to-be's are more comfortable on their left side and therefore they lie still longer, which is important to get good images. And then on the bottom right, you can see that we use the Doppler ultrasound device for fetal cardiac gating. Then the team, who should be on your fetal CMR team if you would like to take it in your center. So first of all, you need someone to scan your patients, a technologist or radiographer. We have trained 2 technologists in Lund. You need your referring and reporting physicians. In our case, we have the fetal cardiologist who refer the patients after echo and the pediatric radiologist reporting on the images. And then we have engineers who help develop our fetal line, who develop sequences and image reconstructions afterwards. And it's very important that this team is working together. And then for safety, that's the question we get a lot, mainly from the volunteers and the patients. So what we do is to remain within standard limits when we're scanning. And on the scanner, this is called normal mode. And what it actually does partially is to limit the energy deposition in the body, which is called the SAR limit. This also means that we have to reduce our flip angles. We do not use sedation nor contrast agents. And then about hearing, that's also a question we get quite often. As an adult, you're very well protected against the sound by using headphones. We cannot provide this for the baby, but there have been many studies at neonatal age and later in development, I think preschool, that have not found any differences between children that have been in the scanner during pregnancy and those that have not. Then the outline of my talk, I will talk about how you can use your standard clinical sequences to get to help your fetal line, what you can do if you add fetal cardiac gating, and what you can do if you add an engineer. And just to give you an idea, with your standard clinical sequences, you can have a lot of information in about 15 minutes. If you do the fetal cardiac gating, you need approximately another 10 to 15 minutes. And then with an engineer, you can continue as long as the mother is comfortable to be in the scanner. We usually limit our scans to about 1 hour. So what can we do by using standard clinical sequences? So one sequence that is mainly used is a standard balance SFP localizer for cardiac anatomy. This is probably something you use in your pediatric cohort as well. So in the images here, you can see a transversal slice on the top left, the coronal view, and a sagittal slice of the heart. Slice planning is fairly easy, and 3 stacks can be acquired in just a few minutes, including planning. So that's quite fast. An added bonus is the visualization of extra cardiac anatomy, as you can already see in these images here. And just remember, you're imaging a tiny moving target, and therefore we acquire our images with negative slice gaps, so you have overlap between slices. In reality, this means we have about 30 to 50 slices per stack, which is quite a lot, but it helps you. So this image here shows how we can use an interactive sequence to help us planning, and this is an example in an adult, but you get the idea. So in the top panel, we have already acquired images, and then in the bottom panel, we have the interactive sequence. So when you plan the yellow slice in the top panel, you can see how the interactive sequence changes the view. This is extremely helpful if we move if we image a moving target like we can see here on the right. Babies never lay still, and I think the most challenging part of fetal CMR is actually to plan all over, because when you've planned, 2 minutes later the baby can have a completely different position, and I think that's the most challenging part. And then you can also use a real-time cine to capture cardiac function. This image shows you short axis real-time with a high temporal resolution but low spatial resolution on the left, which is a technique dated back from 2005, but on the right you can see what we can do more recently. So it has both high spatial and temporal resolution. And then lastly, with your standard sequences, you can also see if there is the nutmeg pattern, which is associated with a poor diagnosis. So the image on the right shows the nutmeg pattern in a 35-week-old fetus with hypoplastic left heart syndrome. And by using a black blood sequence, we can see this. And Sol and all have found that this is associated with a high mortality, or actually 100% mortality, but recent studies are looking into this to see if there is something, if this mortality is always the case. Sorry. So what can you do if you add fetal cardiac gating? The most basic sequences already give you a lot of information about the anatomy and even about function. But if we add gating, and I hope everybody can see this on their screen because the contrast is very poor, but here we see a short axis cine stack. We can follow it all the way through. And this has been obtained by using the Smart Sync for cardiac gating. And we have both high spatial resolution and a high temporal resolution. And then if we have cardiac gating, we can also do flow imaging. So the images on the right show the planning of the flow on the left and the magnitude on the right. On the top, we have measured flow in the descending aorta at the diaphragm level, and on the bottom, we have measured flow in the umbilical vein just after entering the fetus. And typical flow curves, we should play. Typical flow curves for the fetal descending aorta and the umbilical vein are depicted on the left. And then what can you do if you add an engineer? And I will give you here 2 examples from Lund. The first one is a 3D volume. So far the fetal CMR gives flow and cardiac volume, but adding a 3D fetal volume sequence would allow you to normalize the flow and cardiac volumes to fetal weight. And this makes it possible to distinguish between pathological and normal values. So the image here shows a 3D model of a fetus based on a 3D volume sequence. And it will be very time consuming if you have to manually segment this, but Ruud et al. Have created an automatic pipeline using deep learning, which makes this possible in seconds. And then these images show the first true 3D cine acquisition. The same acquisition has been reformatted to a short axis view on the left and a 4-chamber view on the right. The benefits is that these techniques allow for minimal image planning and viewing of all orientations after the scan. And current work is on improving the image contrast between the blood and the myocardium.
There's just one question already for the contrast. No,
yes.
what was it like from Jack Knight? How long is the 3D volume acquisition?
It's almost, it's just under 4 minutes.
Okay. And
yes.
How long is the post-processing then?
About 1.5 hours.
Okay. And then you get the images straight back to your PAC system, so on the screen, or is it like offline reconstruction and then like with MATLAB or something?
At the moment, it's completely offline. We are working to get it into PACs.
Okay, cool.
Yes.
Marjolein, when we are now already discussing, I have one question regarding that. So is it also applicable, like this implementation, to other sites? So can other sites also use it, or?
It's not a plug and play package yet. but the pipeline is published, so it could be used if you have an engineer on site. You can definitely implement this. It takes a lot of computational demands. Otherwise, I think it's not that hard to implement it yourself.
Right.
Yeah, thanks.
Yes. But that was almost it. So to conclude, I think that I know a fetal CMR is safe. It can be very quick and easy. In 15 minutes with standard sequences, you can already do a lot and add on to your echo. And it can definitely lead to improved confidence of the physician when you have more information. And for now, fetal CMR improves clinical care in Lund already. So, thank you.
Thanks so much.
Thank you very much. Thank
Should
you,
I
Martin.
stop the screen share?
And
yeah, maybe.
maybe.
So, Heide, go on, please.
Just let's wait a few seconds. Maybe there are coming questions regarding your slides. Meanwhile, I have one question, and there was also one from Monique Haag from Leiden, from LUMC, and it refers to the safety actually. Do you have like a maximal scan time or threshold when you say, okay, now we stop scanning because now it's like the threshold is over? Do you have something like that, or?
No, not regarding like energy deposition. The main reason for aborting the scan is because the mother-to-be is getting uncomfortable and she starts to move around a lot, which makes it very hard to continue scanning.
All right. Okay.
I
And there was
think
also.
Yeah, I think
Go
the question is also quite interesting, is because I've heard this from different sites as well, that having ethical approval for a healthy volunteers is quite difficult. Do you know if this was a problem in your institution, or haven't you been involved in this?
I was not involved from the start when we had our first ethical applications running, which I think they started. I actually don't know if they started healthy or patients. So I was not included in that stage, but I haven't heard that it was difficult.
Okay.
I think the aim was always to improve clinical care, and we need healthy volunteers to test the methods.
Mm-hmm. Okay, thanks.
Right. Thank you so much. So if there's anybody in the community who has like perfect literature, otherwise I can also share later some literature with you, Monique, that we also refer to when it comes to such a discussion. So I'm happy to share that later. Okay, then I would just hand over to Fabian actually, and I will start sharing my screen again.
Yeah, we thought that it's maybe good to for everyone to know how we have developed in the past as well. So you can already see these green dots, and these are not all. I think overall we have 47 sites now that are actually doing fetal CMR, which is in 2 years, I think, quite cool that so many people have tried and are in use of fetal CMR. So I think this is really developing. And if you go one slide further, Heide, then you can see that we have also tried to measure a little bit who's doing what and how this develops. And you can see in these blue ones are in October 2022, that most of the people have done research. And now in, let's say, May, we can see that most of the people are now also moved to clinical and research, or also only clinical. So we have 6 sites that are only doing clinical work and are not focused on research, but also that most people transform their work also in clinical. So I do both clinical and research, which is, I think, a good sign that it is not only research anymore, and it is also transforming slowly into clinical work. So that's great to see. We are also trying to do on-site demos and so on, and we are traveling around in actually Europe quite a bit, and I just wanted to share our experiences. What is actually the main challenge in that? So, of course, the main challenge is that there is no fetal CMR experience at all. There are no exam cards, and sometimes there are no fetal exam cards for like normal body imaging, for example, the T2 wetted images, and for the cardiac stuff. And that sometimes there's also no technician that is used to perform cardiac scans. So, for example, they do fetal MRI scans, but only for the brain, and the technician doesn't know how to do cardiac scans. So these are quite common problems. When it comes to positioning the transducer, we haven't seen big problems at all. So the right side, you can see an image where you can see actually the transducer, how is it placed, centered above the heart. That is actually the key. Have the transducer focused above the heart, so the fetus can move as much as possible and will still stay into the acoustic window of the transducer. And we normally say if you don't find the heart in like within 2 or 5 minutes, then it's easier to actually make a survey scan, have a look where the heart is, and then place the transducer based on your knowledge of the MR. And if you're doing your first scan and then try to locate the transducer and you have never done this, then this is quite easy because everyone knows how the MR images look like, and then you can actually use that to position the transducer. That's what we normally do, and this works quite fine. And if you go one step further, then we had a big learning regarding the exam cards, because normally we have them also on our website that you can download them, for example, Philips. But this doesn't work all the time, actually. So if we export one exam card and then even if the software version is quite similar and then we import them, sometimes the MR images look like it is the first MR images ever, which is sometimes related between gradient strengths, that they're different, or the hardware is a little bit different. But what experience we made actually is that if you use the standard sequence from the vendor, for example, from this vendor folder from Philips or Siemens, for example, or GE, then it works actually quite fine. Or you use your cardiac sequence that you use for adults, and then you just adapt some parameters. And if you go one slide further, these are the parameters we have found out that they actually work quite nice. This is right now in, let's say, Philips language. So I didn't translate all these ones in different vendor languages, kind of. But you can see the field of view that goes up to a range between like 250 to 300. That there is a fold over suppression. We normally have a slice thickness of 5 millimeters and an in-plane acquisition of 1.7 to 1.5. And I think key is also the flip angle with 60 degrees. I think for Siemens, we actually had it at 70. We tried to have a quite fast temporal resolution of here 24. So in adults, is normally higher of 40, I think 45 or something like this. So of course we need to be a little bit faster here. And we have a sense factor of 2.4. We try to be in breath holds, like, 11 seconds is normally okay. If you can get it shorter, it's of course better. For 3 Tesla, it is very important to have accurate shimming. So we do an adaptive shimming and try to have the shim box just on the heart and don't have some signals from the fluid in there, because this is high signal intensities, and then sometimes the RF shimming takes this into account, and then you don't get a proper shimming for the actual cardiac tissue. Here is, I think, one comment from Karen, and she says that to alter the TR on Siemens scanners, alter the number of segments to lower the TR. So because I don't understand that, I maybe allow her to speak, and then this will be easier. Karen, here you are. Can you quickly explain what you meant?
Yeah, so on Siemens Scanner, you'll notice that the TR is actually grayed out, so you cannot type in the specific temporal resolution that you exactly want to do. So what you need to do is adjust the number of segments, and this will then periodically adjust the TR automatically for you. So if you want to have a greater temporal resolution between like a TR, so a higher TR, then you would go up on your segments. And obviously for the fetal scans, you want to be as quick as possible, go down on your segments, then this will reduce the temporal resolution.
Oh, okay, cool. Thanks. I think now I understood it. Hopefully everyone else. Thanks, Karen.
No problem.
Are there any comments on that from anyone else? Alex Barker just said case-based lines, segments are case-based lines per segment.
Yeah.
Just for clarifying this. Thanks, Alex.
Yes, that's correct.
Okay, cool. If there are no further questions on this, we move on with our cross-center experiences of fetal CMR, which will be done by Haida, I guess.
All right, so we have already presented our Vienna experiences that will be presented by Roland. Dallas will be presented by Muniz, and there will be Sophia from Munich. So let's start with the first question here. We are interested in your fetal CMR experiences just in general before we start going a little bit deeper. So since when do you do fetal CMR would be interested for us, as well as your frequency of scans that you do. Maybe you, Roland, you can start commenting on that.
Of course. Got it. Thanks. We started doing fetal CMR late 2018, but again, we the type of things. And we want to these technical challenges, overcome these. And
Roland, sorry, I need to interrupt. We barely can hear you because there's like a strong echo.
Okay. Is something I use to prove it?
Is your speaker different from your microphone?
Yes.
I think now it's better already.
Okay. Now?
It looks like that you have multiple microphones on, or you have two speakers on and only one microphone. Do you have two speakers from different sources? Maybe?
I think that.
Okay, this is difficult.
Maybe we just go over to Sophia then, and Roland, you can maybe check whether you have two speakers. Okay. So Sophia, can you comment on that?
Yeah, so we have been doing fetal cardiac MR for a little less than 1 year now, but with a quite low frequency, so maybe 1 or 2 scans per month.
All right. What about you, Muniz?
Hi, yes. So we started in late 2021. So we started thinking about it. We had a neonatologist, Dr. Rachel Leon, who was interested in doing some fetal work, and that triggered. And I'm a fetal cardiologist as well, so I was interested in starting up our fetal CMR here in Dallas. So the way it works now, we've created a good workflow. We're still doing it under research, so all the patients are consented, although we do have really good support from the radiologist, so we could potentially we do fetal MR all the time. We just don't do fetal cardiac MRIs as frequently clinically. So everything is done through research, and we've over time, we now at a rate similar to what Sophia mentioned, about 2 to 3 scans a month.
Right, thank you. Roland, can we try again to talk
yes.
to you?
What about now? Is it already better?
Yes, now it's better.
Yes,
Thanks.
okay. Well, okay, so as I said, we started back in 2018 with fetal types. We've been using the certified model smart thing for approximately a year, and we currently have 2 fetal MRIs dedicated to cardiac imaging.
All right. Thank you, Roland. It's still difficult to listen to you actually, so there's still an echo, but yeah, maybe we can fix it during the next questions. So coming to the second one that is interesting for us, now we dive into in-house processes. So we would like to know whether you have any standard procedure for your patient referral, because we know that it really differs among regions and also among sites and hospital. So it is very interesting for us to know whether you have any standards there, and how also is it clarified with reimbursement? Do you have any information about that to share with the community? Maybe we start with Munis.
Okay, excellent. So as I mentioned, we're still under research. We do, though, have created a really nice awareness in our heart center and throughout the MFM maternal fetal medicine community that we have the capability to do it. So the process comes, the way we get the patients is through our fetal visits, fetal cardiology visits. They get offered a fetal MRI to participate in research. If there is a clinical question that is, for some reason here in the US, sometimes we have issues trying to get studies approved through insurance. So logistics that may, sometimes we do facilitate through research studies, some clinical studies as well. The reimbursement I have asked around, and it will be, we haven't done, as I said, anything clinical, but it would be billed as similar to what a fetal MRI is. A fetal MRI, it usually will end up being a complete fetal MRI with a fetal fetal CMR as well.
Right, thank you. And the experience from Munich, Sophia, would you like to comment on that?
Yeah, so we are also doing the CMR in a study setting where we have a study on fetal lung development. And of course, those scans aren't reimbursed. And then we also do clinical CMR, and those fetuses or women are mainly referred to us via the perinatal center for congenital diaphragmatic hernia. So we do the fetal MR anyways, mainly for purpose of associated malformations and also lung volumetry. And then we do additional sequences for the heart. And this is reimbursed, obviously, as a clinical scan, but not mainly for cardiac indication, but more for the diaphragmatic hernia indication then.
All right, great. Thanks, Sophia. And now we also know that the audio problem has been solved for Roland. So Roland, thank you for that. If you also want to comment.
Yes, sorry for the inconvenience. We do have, no, let me state this other. With an overall of over 600 fetal MRI referrals per year, our Department of Neuroradiology is one of the largest fetal MRI referral centers in Central Europe. And regarding the workup of fetuses with congenital heart disease, most of the fetuses screened by ultrasound and diagnosed or suspected with a fetal congenital heart disease are referred to us by either the obstetrician or our team of fetal cardiologists. In a recent paper published by our group in the Journal of the American College of Cardiology reported the spectrum of MRI findings in 427 fetal CHD cases. In our experience, fetal MRI is especially valuable in the evaluation of the placenta and the brain, in addition to the fetal heart. Thus, all of our fetal MRI examinations are reimbursed, but currently, unfortunately, there is no dedicated reimbursement for a dedicated fetal heart workup.
Okay, thanks. Just I have one question to Roland. Sorry. Is there any like major cardiac indication that the patients get referred, or is this mainly just every CHD case, for example?
It's a part of the standards protocol.
Okay.
All right, then let's jump to the third question. And now we go into fetal cardiac images, which is of most interest for all of us, I believe. And there we ask our participants or our experts whether they would like to show some images, like also the first and the recent images, like also like images at the beginning that did not work so well, and what were the problems, what is the learning curve, and have there been or are there any important considerations to take? And there we will start with Roland from Vienna.
Thank you. I would like to say some words to the learning curve. The learning curve was a steep one, I hope I can say so at least, concerning the conduction of the examination. That means concerning localization of the fetal heart and of the optimal position of the Doppler ultrasound transducer, concerning application of the transducer to the maternal abdomen, and application of the coil. I didn't bring you images from the beginning and from now because I think this does not depict the true development. A comparison of those 2 points in time would assume that image quality automatically, more or less automatically, improves with experience. But there are, in our experience, other factors that play an important role, because we try to obtain the standard cardiac planes that are known from adult CMR. And these planes, of course, require elaborate planning and are quite easily lost because of fetal or even maternal movement. So if you take a look at the images, I want to show to you, they demonstrate exactly this. On the one side, you can see quite well-planned planes, but on the other side, you can see non-diagnostic planes because of movements of the fetus by just a few millimeters. So this is what I think is most important to consider regarding the learning process. You get better in optimizing the external factors quite easily and quite quickly, but there are some things such as the fetal movements that are just beyond our control and that may result and probably will result in poor image quality. Yes, those are images.
Let's jump to a better case.
Okay, these images, are they moved? Yes. Here you can see a long axis in the 2-chamber view. On the left-hand side, in the middle, there is a quite well-planned or well-depicted 4-chamber view. And on the right side, you can see the short axis in the 2-chamber view. That was a fetus that lay quite still and unmoved. The former pictures were the opposite. Could you maybe jump back for a second?
Yeah, trying. Okay.
Here you can see this should have been a long axis 2-chamber view, but the fetus moved out of the imaging plane. So you can see the resulting planes are non-diagnostic.
All right. We need to move on a little bit. So let's jump to this one.
Yeah, here you can see a beautiful 4-chamber view.
These are all quite young gestational weeks. What have been your experience with these young weeks?
The young weeks are also quite good depictable, the hearts of the younger weeks. So we made the experience that they lay quite unmoved, that they do move that strongly. So the resulting pictures are quite good in the quality. Surprisingly, actually, because we would have thought that they would move a bit more because they seem to have more space in the womb.
Yeah, that's very interesting. Actually, I'm looking forward to everything that is coming up there. So you are also scanning lower gestational weeks in the future, right?
Yes.
All right, exciting. Okay, now let's move to. Thank you, Roland, for this experience. And now let's move to Sophia. And you please share your slides on your own, Sophia.
Mm-hmm. Okay, can you see?
Yes.
Yeah.
Yeah.
Please.
So yeah, we basically made very similar experiences. So it's very hard to get the view right. And our experience is that in the beginning, it might be useful to team up a technician who is experienced in fetal MRI and a technician who is experienced in cardiac MRI. And I think if you team them up like this, it have a better chance of getting both right, the fetal and the cardiac part. So this is an example of a 2-chamber short axis in a healthy fetus. And then I'd like to move to the next slide, but unfortunately right now, not working. Here. Yeah, and then I'd like to present one case and ideally also get your ideas or a little discussion about it. And this is the case of a 29th gestational week fetus with a congenital diaphragmatic hernia. As you can see, this hernia is left-sided with a liver down, and you can also see the mediastinal shift here. And this was 29th week, and we did lung volumetry. So that was about 33% of age adequate lung volume. That's what we usually do for the workup here. And then here the fetal cardiac MR. Here you can see that the plane is a little bit off, but and this is now weird. Doesn't matter. So, and here you can see a little bit of flapping of the septum already. Couldn't really comment on the size of the right ventricle. The left ventricular function was normal. The ejection fraction was normal. But there was suspicion of a little bit of wall movement. And then we did a movement disorder, and then we did a follow-up at 37th week. And then here you can see that you have enlargement of the right ventricle, and you can also see the bulging of the septum towards the left ventricle. So this has aggravated during pregnancy. And then at birth, the echocardiography also showed right ventricular enlargement and also pulmonary hypertension. So this was, I think, an interesting clinical case. And right now we are trying to figure out if this is like coincidental or if really the diaphragmatic hernia per se and the increased pressure in the thoracic cavity are especially having impact on the right ventricle more than on the left ventricle. So this is one of our cases. And so in terms of learning curve, I want to add like one little detail. Apart from the axis, what I've experienced, you can never use enough ultrasound gel because it dries, and then you have a nice signal, you have a nice plane, and then all of a sudden your signal disappears from the air and everything, so there's not no way to apply too much ultrasound. So that's an experience we made.
Yeah, very good. Thank you for this case. Sophia,
Muns,
very
do you have
interesting.
maybe an idea? Because Sophia, you were asking about how this could actually happen, or is there any other, more about this case? We couldn't answer you because, but now you have a specialist here with him, so maybe you can rephrase the question to him, to Muns again, that we maybe have a better idea.
Yeah, so from a cardiologist's point of view, what would be mechanistic or pathophysiologic explanations of the right ventricular burden caused by the diaphragmatic hernia?
Yeah, so to be honest, with diaphragmatic hernia can be a little bit of a heterogeneous disease.
Sorry, Sophia, but I think you're sharing patient data as well.
Oh, I'm sorry. Thank you. Thank you.
It really depends on how the chest structures are affected, and with the mass effect of the diaphragmatic hernia. Sometimes cases where sometimes the ductus arteriosus can be obstructed or have some restriction because of the mass effect, and that can lead to changes, exaggerated RV hypertension. There are so many things that need to be examined carefully. From a postnatal standpoint, after the baby is born, it really depends on their clinical profile and most of these, and the center's capabilities to be able to take care of the diaphragmatic hernia. So that varies a lot. The meaningful, how meaningful that finding is, really varies on the patient's preference, the center's capabilities, and what they can do about it. So I do find that the exam of the heart for diaphragmatic hernia patients, while it's interesting, it may really, because the physiology changes very differently after birth, it may not be as significant. It's mostly the lung, like you said, examining the lung volumes and which diaphragm, right or the left, and the organs and all of this.
Thanks so much, Muns.
Absolutely, yes.
I would suggest that you just continue with your slides, Munis, and so that we can see your cases as well.
I will go ahead sharing my screen here, number 2, and then I'll pull slides. I think you may have to unshare your screen, Sophia.
Yeah.
Share number 2. Okay, excellent. Respect the time here for everybody. As I said, I'm from Dallas. We talked about this. We use a Phillips 1.5. It's a 7-centimeter bore, so it's a bigger bore, which is, if you have it, it's excellent. A bigger magnet is always helpful for pregnant women. We do have dedicated pediatric cardiac MRI in Dallas, so we're very lucky. We also do some adult cases, perfusion cases, and cardio-oncology patients. So it does help us. We're very used not only for kids, we're also used to having adult patients as well. As I mentioned, it is a research protocol. We are new to fetal CMR, but our technicians, we have technicians that have done fetal imaging in general, so they're used to the dynamic aspect of the study. We do have all of this is researched, led by Dr. Rachel Leon. She's one of our neonatologists. We include a little bit of fetal imaging of the brain and the placenta, and we added, since we acquired the device, we've been using it to do cardiac exams. They're mostly focused on anatomic exams. We're trying to improve our fetal imaging capabilities to get to the point where we could rely on it sometimes for screening. And we use it sometimes to do lung imaging. To be practical, this is when we started with only using PPU gated, so pulse ox gated. You could do that. You could practice before, even without, to gate your study and get a little bit of, to get, sometimes the machine, the magnet doesn't even acquire the images unless you have some sort of gating. You can change your heart rate to match an estimated heart rate. That's one way of, and as you see, the images were not, this was early, very early. The images are not reliable. We were not very happy with them, but it is possible, and that is related to a couple of factors. One is what you see here. So this is after we acquired. We've been using the device. The device made the differences for gating wise, but I think we realized that the image quality itself is not only cardiac gating, it's not only cardiac motion or fetal cardiac motion, it is also the maternal breathing. So as you see here to the left, the image quality is actually pretty significantly better when you use a little bit of maternal breath holds. Obviously, you have to be very thoughtful and mindful of the moms. We have a lot of breaks where we make sure that the mom is doing well. We do the same exact way that was described in other centers. Have the mom on the left side, on her side more than her back. They like this. We do have, our nurses are really excellent at going in, checking in, giving them some ice, making sure they're some washcloth, just to make sure that a wet washcloth, to make sure they're really comfortable in the scanner. I mean, just being in an MRI scanner is hard, let alone being pregnant and in an MRI scanner. Back to the point is truly breath holding makes a difference. So definitely, if the mom can tolerate, you can get really nice images. Those are short axis images. You can get cardiac volumes, and you can get myocardial function as well as systolic function. And then you can do what we do in neonatal imaging. Everybody who wants to do fetal imaging, you really have to think about the standards of neonatal imaging and apply it to fetal imaging. The image quality is not going to be better than neonatal imaging. The structure is about the same size, so you're not going to see really small vessels. You just have to be realistic and try and find the best use of this technology. The gating device, the team has updated the algorithm for gating. We really like this for gating. It's more flexible. If you go to the work in progress menu and work with the team, they can help you make sure you use this. We use it a lot where we average the number of, so you average it over multiple cardiac cycles, and you really don't lose gating as much using that. Fetal position is important to be, sometimes you just have to give up on the gating. If the fetal position or placenta is in the way, you just have to recognize that there is a problem and move on to other methods of imaging. And then maternal body habitus, you're unfortunately with echo, usually you have poor acoustic windows with maternal body habitus that doesn't allow it, and it really applies the same. It gives you the same issue with the ultrasound that you're using to gate. So that is still an issue for us, and we recognize it. And then later in gestation is your best bet. Is if you want really good extra cardiac imaging, you just have to bring the mom at a later gestation and just get those are really excellent images from one of our subjects that really got exactly the same that you get by echo. So we're trying to optimize these balanced SSFP images to get to that level. And those are two quick cases here showing really nice pulmonary atresia with MAPCAs that you actually, here you see the postnatal CT and you see the fetal MRI. if you get used to the images, you can start picking up the structures that way in the fetal MRI is usually filled with water, so it's bright. So you just get used to it, and then slowly recognize that you can find these structures and you can make this a fetal MRI as complementary as it should be, and just recognize its role. Here you see the left aortic arch, you see all of these nice findings. And then lastly, the well-known use of at this point is examining the lung with MRI. So this is one of our subjects that had hypoplastic left heart with restrictive septum and all the features that are not favorable. And we were able to get the patient the magnet. She wasn't able to get it through clinical exams, and agreed to research, and we were able to show this mild form of nutmeg lung. So it does add to the prognosis. It does add to the overall picture. That's in summary just a couple of cases, and really the big advice I would say is recognize the importance of maternal breath holding. Be reasonable and do your exams later if you want a better image. The fetus is usually more still. You have bigger structures, better signal, and usually you can gate a little bit and more at a later gestation. And that's it.
Thank you, Munis, for this insight. Very, very interesting. So actually, we are already out of time. However, we have another question that I would like to ask. So it's recorded. If you need to leave, just do it and look it up afterwards. I will just share my screen one last time with you. Because I think this is very interesting for everybody as well. So we jump now to, but we talked already about that as well a little bit. So research or clinical application. So anybody of you that would like to mention or to comment on that, like what is your main focus of application? And more important, maybe, what do you believe is the most valuable clinical cases for fetal CMR? Is there anybody in the community that will comment on that? And also our experts are very welcome to answer here. Roland, do you want to comment on that maybe?
Yes, thank you, Heide. I think our focus is to enable earlier imaging. So we try to scan younger fetuses. For example, our youngest fetus was gestational age 19.4. We believe that imaging of CHD in an early stage adds substantial clinical value to decision making and prognosis of the outcome. So that is our main focus, to scan younger fetuses.
Thank you. Sophia, do you want to add anything? Or as well, Munis as well?
Yeah, so far we are mainly using it in research setting to explore effects on disturbances of lung development on the cardiac system. So this was our initial research focus, and we are now just expanding to the clinical arena, but just practicing to, as you said, recognize all these structures and really gain experience in order to be able to add more clinical confidence to the diagnosis, for example, of congenital heart disease. But we are not experts yet, so still in the practicing phase there.
Yes. So, from the way I look at fetal CMR is it's a complementary tool for fetal echocardiogram. It's definitely fetal echocardiogram is an excellent diagnostic tool. So fetal CMR, however, does add a little bit of in critically congenital heart disease with few applications that were mentioned with hypoplastic left heart, intact septum, looking at the lung is important. Sometimes limited fetal echocardiogram because of multiple factors, including poor acoustic windows. Fetal CMR may have an advantage in getting better heart exam with specifically for for vascular structures. So looking at the pulmonary arteries and the aortic arch, that is a very good tool to use it. And then definitely research, just advancing all of these. The work that was presented from the team in Lund is excellent. Just trying to advance tools to get our fetal MRI to be better, and also apply this. This will definitely be applied to neonatal imaging as well, because the more tools we have, the better the quality of imaging that we can provide. And I think any patient that's getting a fetal MRI in general, with the equipment of being able to do fetal cardiac MRI is great, because if you find anything incidental, or if you could examine it more if you have the tools. So I think any fetal MRI, any centers that doing fetal MRI should definitely try and explore improving their tools for fetal cardiac MRI as well.
Right. Munis, do you have any experience with obese patients as well? So there was one question for all of you in the chat, whether you have an upper limit for BMI. Can anybody comment on that, or any experiences?
I would say is, you should always try to image. Obviously, there's a magnet size, so the bore size, that's very important to take in consideration, and every magnet would know. But for a limit, there isn't really a limit, because if you're able to get or find a way, either you do the cine imaging that the team in Lund is doing, or even do other ways to do some sort of correct your images with post-processing, that would definitely solve the problem. The problem with the gating is sometimes with higher BMIs. We still try it, even, we still try it. There are acoustic windows somewhere that you can find more in the, hip areas, or a little bit down in the inguinal areas. Sometimes you can pick some in around the umbilicus as well.
Right. Thank you so much. We have to come to an end. Or is there anything, Fabian, you would like to add?
Right now, I'm very happy.
Yes, me too. So let us invite you. Thanks to all presenters. Thanks to all participants today for this fifth webinar session. I think it was awesome, many learnings. And don't forget that in 2 weeks, there's our last webinar session of this series. You have to register again, and we are very much looking forward to see you all there again. Thank you so much.
Just one comment. I think you have seen it all. Karen Catalyst from Siemens has posted a lot of information as screenshots in this chat about the settings for Siemens MR scanners. So feel free to download them. If you couldn't do that during this meeting, just let us know, and then we will send you this as well, because we will have this stored in our chat. Okay.
We can collect that and send it around.
Yeah. So just send us an email, and then we will send all the information Karen just provided here to you via email.
All right. Perfect. Thank you, everybody.
Thanks so much. Thanks to all the speakers. Wonderful experiences. That was amazing.
Thank you.
Thank you, everyone.
Bye.
Yeah, bye-bye.
Bye-bye.
Thanks, everybody. Bye.
Okay, thank you. Bye-bye.
Thank you, Roland. Bye.